Okay, hi everybody, and welcome to the Phi Delta Epsilon Race and Medicine panel. My name is JaNiese, like Elizabeth said, and I am currently the president of the Iowa Alpha chapter here at Drake. So tonight we're joined by 5 panelists, all who have different experiences with race and medicine. And we will begin with a time of just pre-organized questions that I will be asking to the panel, and then we will open up with a question and answer time. If you have any questions, just put it into the Q&A at the bottom of Zoom, and we will get to that, and Elizabeth will be moderating that. So to start off, would each of the panelists just introduce themselves and give your background?
Sure, I'll start. My name is Victor Medina. I teach Spanish at the Department of World and Language and Cultures. My experience has been teaching in the upper educational system, universities. I started teaching in Omaha, and prior to that, I worked in the medical field for 20 years as a medical assistant and ophthalmic technician. And that's it.
I can go next. Hi, everyone. My name is Erin Lain. I serve as the Associate Provost for Campus Equity and Inclusion. And while I don't have a lot of experience working in the medical field, I've certainly been a patient and experienced it from the patient end. And I also have done a lot of research in areas of implicit bias. So I'm hoping to maybe share some information about that.
Trying to unmute myself. Hi everyone, my name is Andrea Kjos, Associate Professor in the College of Pharmacy and Health Sciences. I think I'm probably here by the factor of what I teach. So I teach a course in medical sociology, and I also teach a course in the healthcare system and healthcare policy.
Hi, I'm Cassity Gutierrez. I am the chair of health sciences and an associate professor in that program. I also think I might be here because of what I teach in my area of research, but my practice area before I went into academia was working with racial and ethnic minority populations to help address health disparities. That's my area of research. I teach epidemiology and cultural competence courses, and I just want to thank you guys for giving us this opportunity to be on the panel tonight, and I'm excited. There's a lot of people tuning in, so thank you again.
Hey everyone, my name is Dr. Walpole. I'm a second-year psychiatry resident at The Ohio State University. I am here on behalf of the International Board of Phi Delta Epsilon, so I'm currently the resident representative. And I guess, live this topic in my daily practice and had a very thorough education in implicit bias and racial disparities in medicine, being at Ohio State. We're one of the colleges of medicine or schools of medicine that really excels in this area and has one of the most diverse classes in the country when it comes to medical student representation. So this is a topic that I'm really passionate about, and I'm excited to talk to you more about it.
Yeah, so thank you all for coming. Our first question this evening is, how have you seen racial and cultural inequities affect medicine and people's healthcare?
I guess I can start with this one since this is probably very much directed at me as a medical practitioner. So I wrote down some stats that I looked up today. You know, this is something that I live on the daily basis, but not something that I guess I look at data about very often. And I was curious, like preparing for this talk, what this really looks like, especially in the field of psychiatry, which, you know, obviously I'm biased. I think it's the best profession there is in medicine, but it's probably one of the professions that has the most significant racial disparities. So some of the statistics that I very quickly Google searched and that are very easy to find, non-Hispanic Black Americans have twice the likelihood of being diagnosed with severe mental illness like schizophrenia compared to non-Hispanic white Americans. Minority individuals have higher rates of disability when it comes to mental illness. There's less prevalence of depression in Black Americans and Hispanic Americans compared to white Americans, but this depression is more likely to be severe, persistent with horrific comorbidities. Individuals who identify as biracial have an even higher prevalence of mental illness. And when you look at the justice system has some of the highest rates of mental illness, and minority individuals are more represented in the justice system than their white counterparts. You know, the statistics go on and on and on. And when you look at the breakdown of just percentages of prevalence of our diagnoses in, you know, different populations, and the percent that actually seek services with these diagnoses, about half of all white individuals who have a mental illness diagnosis get services, compared to 31% of their Black counterparts, 22% of their Asian counterparts, 40% of their Hispanic counterparts. I mean, these statistics are staggering. And when it comes to actually seeking the services, there's more stigma, there's cultural implications, there's language barriers. I mean, if you think about the kind of stuff we talk about in psychiatry, it's hard enough to tell a stranger, let alone a stranger with an interpreter. So now you're having to share your story with two individuals instead of one individual. There's just so many systemic issues that prevent minority individuals from receiving good psychiatric care, psychological care. It's something that I see every day in practice. And, you know, like I said, these statistics, I could do an entire hour of just what this looks like. We do the best we can in our department at OSU. We're actually actively looking at this. And one of my co-residents just presented last week that our Black patients that come into the emergency room are 4 times more likely to be restrained than white counterparts with similar diagnoses. Nothing about what they look like coming in, just the fact that their skin's a different color, they're more likely to end up in seclusion and restraint. So we're looking at these, we're working to address these even within our own healthcare system. But we definitely have a long way to go.
Can we, are we allowed to expand this beyond just psychiatric areas of health? Okay, perfect. So like I had introduced earlier, a lot of my work is with health disparities. So we know that there has been a lot of population improvements in health over the years. However, what we see is that some disparities have persisted and those gaps are widening. So we know that people of color and low-income individuals historically face greater barriers to accessing care, have higher rates of uninsurance compared to their white counterparts, and often might have lower income. So we get into some of those social determinants of health also. Data also shows that disparities in some health outcomes, such as heart disease mortality rates amongst Blacks and diabetes mortality rates amongst American Indian and Alaska Natives have widened over time. So, I mean, there is just so many different disparities that exist. Things such as actually having a primary care doctor and using them, having poor health outcomes. So one of the things that we see a lot of times with, I can think of cancer, for example. Sometimes our minority populations might have a lower rate of cancer, an actual lower incidence of cancer, which incidence is new cases of disease. But yet they might have a higher mortality rate because they're diagnosed in the later stage when it's not as treatable, and then they might not get access to the care that they need to treat that. So again, I don't want to take up too much time, but we know that there is disparities when it, like a range of health conditions from asthma to diabetes. I mentioned heart disease disparities. We know there's disparities with HIV/AIDS. Infant mortality disproportionately impacts Blacks and American Indian populations. And our Black males have the shortest life expectancy compared to other groups. So, and then overall, all of our low-income individuals across all races report worse health status than higher income individuals. So, like I said, I'll leave it there just so somebody else might want to jump on and add to that.
I might just jump in with a couple of thoughts. So when thinking about these disparities, you might be wondering, well, where are they coming from, right? And I think you have to understand the history a little bit, particularly thinking about certain populations of color and the access or how they've been treated in the medical system historically, I think impacts how these disparities have been formed. So if you even go back, 80 years ago when my grandparents who have both passed away, but they grew up in very rural, they're both were African American, grew up in the rural South, in a very segregated society. They weren't they weren't allowed to access certain healthcare facilities, right? And so I always remember talking to my grandparents about that, and there was a real fear and distrust, when talking about health issues that they were facing. I think a fear, one, because they just didn't have access to healthcare when they were younger, growing up in the 20s and 30s in rural Louisiana. And so then when they got into their 80s and it was time to take some of these really, dire healthcare issues seriously, such as diabetes, such as heart disease, it just was foreign, I think, to them, because they didn't have access when they were younger, and because that was very much part of the segregated lifestyle. I mean, you could not go to the hospital, right? Or you had to go to someone in the community who maybe had a little bit of knowledge about healthcare, particularly because they were rural. They lived in a really small farming community. And so I think the history is so important to understand, particularly for you all as you are entering into the profession. It's not like history was there and now it's different. People carry those stories with them. Um, and particularly like if the oral histories and traditions of families and you talk about your experiences, and if those experiences have been, I wasn't welcome, there was no access, I'm fearful because I don't know, that gets passed down. So I think that's very much a part of some of the challenges that we have with these disparities. The other issue, I think both Jessica and Cassity talked about this, is access. Thinking about where can you get access to healthcare? How can you afford it? If you don't have robust health insurance, getting those preventative checkups is not very realistic. And then what ends up happening is the only way you're accessing healthcare is through emergency services, right? And that's not ideal. That's when things are past the point of care. It's just you're trying to treat things acutely and try, and so we really have to be thinking deeply about that access piece in addition to the history piece. I think those are really important things to be thinking about in terms of disparities.
Yeah, thank you. So our next question is, what steps do you believe society should begin taking to reduce racial discrimination?
I can start us off again. And do you want us to think about it specifically within a healthcare context or just generally?
Within healthcare and also general. So
Okay. So I've been thinking a lot about the issues that we've been facing with COVID recently, and I think it's a really good microcosm to think about some of the challenges our nation faces with discrimination, with disparities. And what we know is, sometimes we think about discrimination in terms of like intentional acts against people, right? Like I don't want to hire you because you're Black, or I don't want to hire you because you're Native American. But sometimes it manifests in such complicated ways. And I think COVID has really shown us that. So we know that there's disproportionality amongst different communities of color with COVID. So we know that Black and Latinx communities are really being disproportionately impacted, even here in Iowa, where most of us are. And I think about, why that's happening. I think a lot of it's happening because of socioeconomic differences. So who's able to work from home, who has to go and is working in an essential, kind of essential worker work. So people are being exposed at different rates, I think, because of those disparities. And then when you think about healthcare and like once you get sick, are you seeking healthcare? Do you have access? Can you get there? Those types of things. And then if you think further down the line, okay, eventually, hopefully, we're going to have a vaccine, right? And so thinking about who's going to have access to that vaccine, who's going to be interested in taking that vaccine, and then who also has been a part of the vaccine studies is really important to think about. And so when we're thinking about discrimination, it's important not just to think about those intentional actions like these people are being barred. It's the system surrounding us that really creates these disparities, and that in itself is kind of the basis for discrimination and oppression, right? And so when I think about fixing it, it's not just like teaching. I mean, these types of conversations are so important to have people reflect on, like, how do I limit my own bias? But it's also important to think about those systems that really create the disparities, because that's what the continued discrimination really is manifesting as. So like thinking about COVID, how can we get people to be in safe environments where they don't get sick? How do we get people to have access to healthcare where they can get care and treatment? How do we get people to understand you know, the benefits of certain types of prevention or care, et cetera? It's got to be all of those pieces, right? The first step is educating ourselves, but then it's looking at the different systems and saying, how can we remedy these things so there's those disparities shrink, right? And that when we have fewer disparities in systems like healthcare, that's when we start to see, you know, an improvement within our types of things. So it's really got to be a systemic look at what's going on, and systemic efforts to remedy some of these challenges.
Yeah, so our next question, I believe, is directed towards Dr. Medina, but anyone can answer this. But it says, how can medical professionals create a welcoming environment for patients who rely on an interpreter?
From my personal point of view, that I've worked myself as a medical interpreter besides being a medical assistant. 20 years ago, it was a different story. New laws have been implemented. Back then, you had to provide either an interpreter, pay out of pocket, and new laws have come across all health systems. And you guys were probably children before this came out, but there used to be different hospitals, different clinics, doctors were independent. And there was this move from California all the way to New York to create these big health systems. And when I worked in Omaha, Nebraska, back in 2004, I started work. We were part of, actually, Methodist Health System absorbed us. And there was intense training on cultural competence, be aware of racism, bias. There was a move by these institutions to identify tendencies that you see not only in the population of patients, but also within the system, and to eradicate those types of behaviors from the institution itself. So there's been an improvement in the last 20 years. We still have a ways to go, but I remember I was usually the only one interpreting for patients coming in, and because our clinic was pretty big and we had other disciplines that provided services, it was not uncommon for me to go from one clinic, from the urology to the urgent emergency room, to the lab, to pulmonology, to interpret for patients. Now, the perception back then, before the laws were implemented, that you have to have an interpreter in the institution if you're going to provide medical care for non-speaking, non-English speaking patients. Back then, we didn't have that. So the place where I worked was very helpful that I was there, but I was one of a lot of rare interpreters. Now it's a career that has taken off, and like I said, by law, if you own a clinic or hospital, you have to have either someone on staff or services that connect you to an interpreter. And it needs a lot of work still, but it's better than before where there was none. So at least patients that are not fluent or limited in their English have a way to communicate with their healthcare providers, and that way minimize the dangers of misdiagnosing or not addressing the medical issue that the patient is presenting with. The problem that I still see is that with African Americans, Hispanic Americans, Asian Americans, and now with the influx of refugees that we have coming into the States, we still need more help in providing these bilingual interpreting services. But the road is there, and they are trying really hard to accommodate these patients. But when I was working with doctors, this is a while back, the patients were always mislabeled as poor compliant. And I don't know if you know what that means. Poor compliant means I'm a diabetic patient, I don't speak English, I don't have insurance, how am I gonna pay for this appointment? Then I gotta get insulin, which is hundreds of dollars a month. So these patients, okay, all these minority patients are looking at, how am I gonna weigh this? Am I gonna pay rent, or am I gonna take care of my health? Who's gonna feed my children? Where I live, the doctor is not there. I gotta drive half across town to get the medical care that I need. So these are the things that these patients are facing every day. Unfortunately, we don't have universal health care in the United States. That would be a path to at least relieve some of this problem. But it's driven by private practice, private interests, and these big health systems, unfortunately, are run by profit, and they have limited amount of providing free care to these patients. And what I was going to say was that it was not uncommon to see a doctor label the patient poor compliant because they didn't return to the appointment, is not following up with taking care of his or her health with insulin. So they're mislabeled as poor compliant when in fact they don't have the resources to be compliant. But it is getting better. And the last 20 years I've seen huge improvements, especially by big health systems.
I just want to add a little bit as someone who uses an interpreter almost daily. I will say in-person interpreters by far are exponentially better than video interpreters, which are then exponentially better than phone interpreters. Having someone actually physically present in the room with you, I think puts the patient at ease. And part of that, I think, is the nature of what I do in psychiatry. I have a lot of patients that are paranoid about TV screens and computers and phones. And so when you say, I want you to speak in your language to this person on a screen who then is going to speak in a different language to me, it doesn't do a lot from a trust standpoint. And I think really does hinder care. But if you have someone physically present that can make the patient feel comfortable and at ease, it does help a lot. Now, that being said, in one day I could have 6 patients that speak 6 different languages, and it's just not possible to have in-person interpretation for all the languages that we take care of in Columbus. We typically have in-person interpreters that speak Somali, that speak Spanish, that speak French, and we have a couple other I can't even tell you what they are because I've only used them a few times, but they do pop up every now and then. And having those individuals in person is great because those are the languages we use the most. But with the influx of immigrants coming from all over the world, I mean, we're seeing more languages now than we've ever seen before. And so having those video and phone services is great because they can reach more individuals and do things more quickly. From a provider standpoint, I think it is common thought in medicine, like, oh, I have to see this patient that doesn't speak English. Because you know that walking into that room, your encounter is going to take at least twice as long, if not 3 times as long, because you're essentially having to repeat everything twice, if not 3 times, instead of just having that kind of natural dialogue back and forth. You know, I've gotten myself out of that habit because that's ridiculous. I mean, everybody deserves to be able to speak their own language when seeking healthcare. I can tell you that's not everyone's approach in medicine, and people will actively avoid having to pick up patients that speak other languages for that reason, because it slows down your efficiency. It requires more documentation. It requires more work up front. And I think that just shows a negative side of our healthcare system. And the other component as a provider are family members who want to serve as interpreters. That's something I run into a lot because as an institution, you're required to provide an interpreter, but the patient can decline and ask their family member or friend or whomever is with them to serve as an interpreter. As a provider, that's something I get really cautious of because a lot of times these are languages that I don't speak a word. So I sit there and I have absolutely no idea what is being said until something is said to me. And when, especially it's a family member, like a caregiver translating for someone that they're caring for, oftentimes there will be a lot of back and forth between the family members, like 5 minutes worth. And then the caregiver who's doing the translating will turn to me and say, that's not a problem. And you're like, what was the rest of that 5 minutes? Because there's probably information in there that I need to know in order to make the right diagnosis, to have the educational conversations, to come up with a treatment plan that's going to work best for the patient. And so I think, like, as a country, as healthcare in general, we have to move away from using family members and caregivers as translators to really make sure our patients are getting the best and most equal care across the board.
Yeah, so it sounds like by understanding interpretation, we can then practice better as physicians. And multiple people on the panel also mentioned diversity training or implicit bias training. So, and we have some people in here that teach classes like medical sociology and culture care. So how effective is diversity training or understanding the medical sociology aspects of healthcare?
I will say crucial, and let everyone talk about what they teach. Because truly my medical education would not have been as high quality without that component. I'm fine saying this. Clearly, I'm not a diverse individual. I grew up in a suburban upper middle class family. I went to a great college. I had great education. I haven't had much in terms of like things to overcome. And I say that because I think it gives me a unique lens through which now I practice, because I've had to understand what other people have had to go through. I've had to put myself in other people's shoes to know what it feels like to be in a situation where I don't speak that language, where I've had to overcome these barriers, where I don't have access to the care. And I say that because coming to OSU and getting that implicit bias and diversity training and cultural competency education has made me a better provider. And I think if I wouldn't have had that, I wouldn't take as good of care of my patients. I still have a long way to go. I'm not saying I'm perfect. I'm not saying I have even remotely scratched the surface of all the things that I need to know. But I've learned how important it is and am dedicated to continue learning. So I would say all the people that teach these classes, please speak up.
If I can expand on that, yes, what you were saying, Jessica, is true. And also, a lot of these places where you will be working as a physician, they will give you those classes. They will give you diversity classes, implicit bias classes, cultural competency, because it can also work the other way. And I'll tell you something that happened to us when I was working in Illinois back in '93. It was not uncommon with the older generations, because we're getting better as a society, okay? I do see a huge improvement. But we did have a patient call, and she wanted to know who the doctor was going to be, and she was Dr. Cronenberg. Is he a white doctor? Does he speak English? You know, these are the things we're moving out of that I haven't seen in the last 10 years. So that gives me, you know, a good feeling that our society is getting better as a whole, because it was worse before, a lot worse. And like you said, it's better to have a certified interpreter because of this medical terminology that is crucial in the diagnosis of a patient and better treatment. And when you have a child, sometimes the child will be uncomfortable talking about what the mom has, right? So, and we have to make every effort to have either services that provide medical interpreting or a physical interpreter present, because it's just for yourself too, to protect yourself too, as a physician or healthcare provider.
Andrea, why don't you talk first about medical sociology, and then I'll piggyback out.
Sure. So the class that I teach is a lot more at the, I would call it the macro level perspective of thinking about health disparities. And so one of the things that I do in the courses that I teach is really expose students to the numbers and some of the striking statistics that we're alluding to earlier. And I think that for some students, that's the first time they're really seeing that hard reality in the numbers. And for my science students, you know, they sort of like that resonates with them when they actually see the statistics, and they're really bad. And so helping students sort of process that information, because immediately they're like, how do we solve this? Like, this is terrible. It's really upsetting to me. And they have this sort of emotional reaction to this information. And so one of the things that I'm at the macro level for the courses that I teach. So when I say the macro level, we're thinking about policies, we're thinking about trends with organizations and structures. So when it comes to training and thinking about that, I'm only speaking about like how I sort of teach with the students that I work with. And I forget what I've lost my train of thought now. But I think just kind of understanding the pieces that, trying to unpack with students the reasons why those statistics are there. And sometimes they are related to very overt instances of racism, and sometimes they're not. It's more so related to the things that have been mentioned so far, like access and the way that our corporations are structured and employment and things like that, that aren't necessarily the fault of the healthcare providers. And so in a way, it's like, okay, so it's not necessarily something I can control. That's like sort of how the health professionals are thinking, but it's like, wait a minute, these bigger picture issues that are economic, that are corporate or organizational related, are things that you can impact, but just in different ways than working with patients. And then we talk about things like advocacy, things like using the privilege that you have as being a trusted expert member of society to use your voice and make changes in the organizations where you work, or advocate for policy changes that can then have downstream impact on communities and patients. So I think that, I know that your question was specific to like diversity trainings, and that's something that I think is really still being evaluated, but from the research and some of the initial findings that I've read about that, is that as long as there's accountability within organizations to, you know, make sure that behaviors in overt instances are being disciplined or called out and being talked about, that they can be very, very effective tools to help just inform people and understand that sometimes things aren't blatant, but there's still things that we need to point out and talk about and correct. And so I guess that's what I'd comment at this point on that.
So Dr. Kjos and I are actually in the same college, and I think both of our classes are possibly electives. Is yours an elective for GCPH too? Okay, for the global and comparative public health concentration, but mine is actually required for our health sciences students too, although it's open to other students. So it's called Culture, Care, and Health Literacy, and we look at all different levels. I don't think of cultural competence as something you ever achieve. I think it's a continuum, and you should constantly be working towards it. And so one part of that process is, learning about different cultures. Now, there's a lot of studies out there that have kind of mixed reviews on this. And something I always caution my students that when I'm talking about this, you might start to develop some stereotypes. And just remember, at the end of the day, these are individuals. And there's a lot of different things beyond just race and ethnicity that go into somebody's culture. And so I think that was the only caveat that I like to give is I think the trainings are very necessary, but again, the research has shown sometimes that can actually result in overgeneralizations and stereotypes. In that course, again, I'm sorry if I sound like an infomercial for it, we do actually learn how to interact and utilize interpreters effectively, and we practice that skill. So we're very skill-based too. We definitely look at the data. We have a whole unit on health disparities. And then we end with health literacy because we know that there are many Americans that don't speak English at home, but even if they do, and they have, actually the statistics are that many Americans, regardless of what their first language is, have limited health literacy. And so we spend, again, the final unit just addressing that and strategies to improve both oral and written communication for our audiences with low health literacy. But just one other thing I want to note about it, the thing that I think is most important is not just getting the information in the classroom, but interfacing with individuals from diverse populations. And so in our class, we do a community engaged learning project, but that's just a snapshot. If you can engage, I guess this is almost going towards a recommendation, that if I can give any advice to you at the undergraduate level is get as many opportunities to, and it doesn't even have to be in healthcare settings, but do community engaged learning. That experiential piece is pivotal. And I feel like you learn just as much through that as you're gonna learn in the classroom with me. So I've done a lot of research in this area and know that it is required in most healthcare professions now at the graduate level, this type of training, but it's still relatively unique to get this type of training at the undergraduate level. And most students, after they get it, whether they take something with Andrea or myself or another department on campus or interfacing with Dr. Lain, they always say, wow, thank you so much, because this came up in graduate school and I knew I knew a lot about this already before, in contrast to their peers. So I think there's a lot of options at Drake, not just our classes. And so I would just say, try to take one or a couple of those.
Can I just jump in real quick? So I'm coming at this so I'm a lawyer and I do some trainings with our law students about implicit bias because that's another field where we see a lot of disparities and it's a real challenge. And here's, there's very mixed research out there about the impact of trainings. But here's what we know. So like the law field, I think the medical field, some of our disparities come from implicit bias. Some are based on other circumstances like socioeconomic status and access and those types of things, but some are based on implicit bias. And I was so struck by what Dr. Walpole, I'm hoping I'm saying your last name correctly, thank you, said about restraint of certain individuals coming into different facilities. And I thought, that's some of that's got to be due to implicit bias, right? Why are we restraining certain patients while we're not restraining others? And so I read this really great book. It's a really short, easy read. It's called Deep Diversity. And one of the things the author did, he really wanted to work on his own implicit bias. He took the Harvard Project Implicit test, which if you haven't taken those tests, I highly recommend that you do. Just Google Harvard Implicit Bias and it'll be one of the first links that come up, but it's this association test that kind of tests your reaction times. And anyway, so he took one of those implicit bias tests, found that he had some deep implicit biases against different racial groups. And so what he ended up doing, he was living in New York City, so he wanted to replace his associations. And so every time he rode the subway in New York City and he saw like an African-American man, he told himself over and over again, he's like, that's a professor, or that's a doctor, or that's a lawyer. And he was trying to replace his implicit associations based on stereotypes that, you know, all Black people are poor, what, you know, whatever the negative stereotypes were. And then after a while, he like made it his personal mission to like try to replace the stereotypes in his head. And after a while, he would take the implicit bias test, and he saw significant improvement. Now, I'm not suggesting, like, maybe that would work for you, I don't know. But I think the moral from that story is that the trainings and the classes are so critical, but they have to be the starting point. You know, as healthcare professionals, just like lawyers, it's something that you have to work on personally, and you have to really deeply examine your own cultural positioning. So like how you grew up, the beliefs you had, and understand how that can lead to bias, because it's just human nature that we have these biases, and that if we aren't proactive in addressing them, they're always going to be there, right? And so we really have to be like the guy who's, you know, like checking himself when he's thinking about stereotypes. It's got to be a lifelong, like Professor Gutierrez says, it's got to be a lifelong practice, right? That we're always trying to work on this. And so that's what I would suggest to you. One, you have to take those opportunities so seriously when you have them presented to you as far as trainings or classes, but then it's got to be a personal mission to work on it. So.
Thank you. So before I ask our last question, I just want to remind the audience that we do have a question and answer box. So put any questions you have in there, and hopefully we will have a chance to answer those. So within that question about diversity training, a lot of you mentioned things that happen in medical school or in your professional times, but what are things that we can personally be doing as pre-medical students here at Drake or wherever you're tuning in from, that we can mitigate the inequities that exist within the medical field or just on this campus?
If I may start, hold more meetings like this one. When the initiative to foster change comes from new generation of medical students, it has a much greater impact because you're going to bring new ideas into the medical field. In a way, you're going to kind of change the status quo. You have fresh ideas, and as you can tell, the pandemic has highlighted some of these inequities that we as society must resolve if we want to continue moving forward. And also recognize the cultural background differences you will face when treating your patients. Cultural competency is the key. And I'm very grateful that Drake decided to implement, and I'm not plugging it in, but we do have a bilingual medical interpreting program where we give it a global approach of what we're discussing here tonight, from law to medical to just being an advocate, because the role of the bilingual interpreter is not just being there translating. Okay, you're there as an advocate for the patient. You're looking after the rights, and you want to make sure that the patient is well taken care of. So there's a lot of instruction going into what it is to be a bilingual interpreter.
So we have a question in the Q&A section, and it's asking about, so some students can't take the medical sociology class. Some of these classes are like super particular to your major, to what college you're in, but we still want to make change. What are your recommendations as professors about what we can do to learn about the disparities in medicines and change it while we're here?
So I think that's kind of similar to what we were addressing anyways. So I'm sorry if I go tangential a little bit, but one of the things, if you aren't able to take a class, there's so many online training programs out there that exist that are very good, and they're very free, and they're available through like the AMA, the NIH, CDC. One of my favorite resources. I don't even use a text in my class anymore because it changes so much and there's so many good resources out there. I use the Office of Minority. The Office of Minority Health is, it's almost like my text for the class. I like that. And that keeps you up to date on a lot of different information. So that's a great resource. I have a little bit of a different advice if you want to make a difference. One of the things that really impresses upon me that I hope to make some impact in my lifetime is the number of racial and ethnic minorities that go into health professions. And so I see beyond educating yourself, I would say encourage your peers that might not otherwise think about going into a health profession, because just to give you guys some perspective, we know that the African American population is about 13% in the US, yet they're underrepresented as only being 2.6% of doctors. And even moreover, our Hispanic population is almost 19 or 20% and growing, and yet only 3.8% of our doctors identify as Hispanic, Latino, or of Spanish origin. So just know they're vastly underrepresented. And if you can think about, I can't relate other than I came from rural America and I never saw a lot of doctors or other healthcare providers. And so that's kind of why I went the non-clinical route in public health, is because I just didn't see it. I didn't see it for my family, paying my way through school. And so this is the same for a lot of our racial and ethnic minority populations. If they don't see that and they might not have the mentorship, they might not feel the self-efficacy to pursue those areas. So I know that, again, that's slightly tangential, but I think even encouraging, if you guys want to help encourage prospective students as you interface with them and just empower them to pursue these pathways.
I have a book recommendation. If you're not able to take a class, there's a really great book that I recently read called Black Man in a White Coat. I don't know if anyone's, yay, okay.
Literally just finished it. So we have a book club now, and that was my class's book for this quarter, and I just took it back. Otherwise I would have grabbed it right off my desk and helped.
Anyway,
and he's a psychiatrist.
Yeah, it's a great book. And so if you're wanting to learn more about some systemic issues within the medical field and healthcare, that's a great book to pick up, particularly if you can't take one of the classes.
And I'd be happy to send along like a full list. I mean, we have a diversity book club at this point that are each of our, like, we call them PGY classes, but like each class of residents, so interns, second years, third years, we all read a book each quarter. I'd be happy to send you guys a list of some of the books that you can read kind of on your own. They're, like I said, easy reads, great information in these books. I can't wait to read the next one.
Yeah, I was just going to recommend books too, but I know you students are busy, so I'm like, I hate to give you more reading assignments. But honestly, maybe slightly down the rung of reading list, which I can give you many books that have impacted me and I think have impacted some of my students. But aside from those, which I'll tell you in a minute, just a couple of them, subscribe. If you're a pre-med student, I really do recommend you subscribe to the journal called Health Affairs. And it's a policy-focused journal. And even if you just get the table of contents every month, they publish a lot of research, good quality, high issue, high quality research on things like socioeconomic status, racial disparities across all kinds of different communities and populations. And they also have a blog that's actually very easy to understand, and a Twitter account. So like if you just want quick, like things that pop up or kind of come across that are like, oh, I'd like to learn more about that. I really do recommend that journal. I find it to be very timely and high quality. So if you're kind of wanting to dip your toe into something but you're not sure, I would recommend that. The other book that I use very regularly in my medical sociology class that I highly recommend for pre-med students or any pre-professional student, and I'll pull it off my rack here. It's called, let's see if it'll focus, The Spirit Catches You and You Fall Down. So it's about the Hmong culture. And it takes place in the 1980s and 1990s in California with the refugee community that come over from Laos and Vietnam. And this book really gets into the history and the context for the Hmong community coming to the United States, but also the story is really about a little girl with epilepsy and the cultural differences between understanding the consequences of epilepsy in a small child. And so that book is really eye-opening because it's a very tragic story, but it's a story of health professionals trying really hard and it just not working out with making inroads culturally and medically with families. So that's probably my top reading recommendation. And then related to historical context for the trust that a lot of communities lack towards health professionals, I think regaining that trust is a very important theme that we should be thinking about in recent times. So this is a book I'm working on. I haven't finished it, honestly, so I can't give you the full review, but it's called Medical Apartheid. And it's dark. I will warn you, it's gonna take a little bit of processing for me to like work through this book because it's really hard to read. But if you really wanna know the history of medicine with Black Americans, you need to read this. So those are
book for next quarter.
So I think it's just being willing to, you know, kind of have this humility that it's hard stuff sometimes to digest and process. And so maybe a book club like was recommended is a good idea because that way you can talk through some of this because it can be very heavy material. So I guess that's my only maybe other advice.
Dr. Kjos, could you repeat the name of that journal that you recommended? I cut out.
Oh, I'm so sorry. It's called Health Affairs. So Health Affairs is the journal, and you can just subscribe to their monthly table of contents, and you can also access most of those articles through our Coles library. Otherwise, you usually have to pay to get articles because I'm usually downloading things all the time.
I just wanted to add one more thing. Sorry, I was going to say that I think when you guys are preparing, you think of maybe doing more traditional things such as being patient care techs or a lot of students in health sciences are CNAs. But one of the recommendations I had read years ago, and I think this still stands true, is if you possibly, if you're looking for part-time jobs, pursue things such as patient navigation, because patient navigators get to see it through a different lens, or they're really working with families on, and they have to learn to listen and help them navigate a really complex healthcare system. So that might be added to your list of, I know you guys are busy, but I know some of you have part-time jobs or summer jobs, that those would be a good position that would give you some perspective. And one more, and like I said, this is a shameless plug, but my class is also offered for any students to take during the J term, and it's always online, not just this year. So it fills up very quickly because prior to this year, it was one of the only online classes, so people could still get a J term and stay at home. But just letting you guys know, if you're not in the major, you can take it during J term.
I have one question for Dr. Walpole. So we talked about how there's like these disparities in the statistics of healthcare providers. And you've mentioned that you've seen how some of your colleagues come into sessions with like interpretation and like those sessions which require a little bit more effort with hesitation and that they don't really want to. So how do you navigate that situation in a way where like you want to promote a more equitable conversation and mindset, but it's difficult to? How do you deal with that?
It's a great question. I probably don't have the perfect answer to it. You know, in general, like I said, through med school and as a resident, I've done a lot of these classes, a lot of self-reflection, which is why I started with, I recognize I'm not a diverse person and I have not had to overcome a lot of things that other people have. And the reason I always bring that up in these kinds of conversations is because I think it gives us all a common ground to start on. So anytime I'm talking with co-residents, with med students, that I get that sense of like, oh, we got to go see this patient with an interpreter, I take a time out and say like, you know, where's that coming from? Is it the time? Is it the effort? Is it something else? because you can't really start engaging in these conversations until you know where the other person's at. You know, I could throw, I know I started with statistics, but that was just because I thought these were really interesting. But I could throw statistics at people until they're blue in the face, and how we have to be a champion and get equitable care for all people. But until you recognize where people are at in their process of understanding their own identity and other people's identities and what that means in obtaining healthcare, you're not going to get anywhere with these conversations. So I always start with, you know, where's that coming from? Have you had bad experiences in the past with patients like this? Is it a time thing? Is it an effort thing? And then typically I'll highlight some experiences that interpreters have honestly saved my butt as a provider. In doing a physical exam with the patient, this was my last inpatient rotation. You know, I was examining a patient, which we still do in psychiatry. We still use stethoscopes and all that good stuff. And I got to the abdominal exam, and the patient had a scar on his abdomen. And I just said, oh, okay, he has a scar. And the interpreter actually stopped me and said, you know, in our culture, that specific scar is an indication that the person has hepatitis C. Never would have known that. I think even if I had done like cultural classes related to that specific cultural identity, I don't know that I would have picked that up nor remembered it. And the fact that the interpreter stopped me and said, hey, that's something that you should probably know about. I looked at the chart, it wasn't in the chart. So I ordered the labs. I realized that this patient wasn't on any hepatitis C medications. The viral load was through the roof. And he basically was harming his liver probably without even knowing it, because it just was a scar. And so I highlight things like that and say, you know, I know that these encounters take some extra time, but actually these interpreters are sometimes literal lifesavers. I mean, we were able to get the patient the medication that he needed to address a condition that nobody knew he had because it just looked like a scar. And I think if you approach conversations in that way, by first understanding where people are at and then highlighting ways that interpreters are actually incredibly useful and beneficial and wonderful members of the healthcare team, then you can start making positive change. And you just, I mean, at some point, you're always going to have somebody that is fixed in their ways, and you can talk to them and have these conversations until you're blue in the face. But I think more often than not, especially like my co-residents and people within the field of psychiatry are very attuned to the needs of patients. I mean, we picked this specialty for a reason, that we truly care about like these kinds of things. So I've had really good experiences with my peers. Now other specialties, I can't say as much. But I would say, you know, if you can even change one person's outlook, that's a win.
Okay, that's all we have for today. Thank you guys so much. We really appreciate you taking your time. It's been a very weird and busy year and week. So I just really want to say thank you for taking your time, and also thank you to all the attendees. Dr. Walpole, there's been a lot of interest in your list of books, so I will send you an email to ask you for that. If the other professors also have book recommendations, I will send an email and I will forward that email out to all of the attendees. Again, thank you guys so much.
Thank you for having us.
And thanks for doing this, you guys. This is a great first step as future healthcare providers. I mean, the fact that you guys are already having these conversations and thinking about this is huge. So keep doing what you're doing. And thanks for having me.
Yes, thank you. Be happy to continue the conversation.